I'm really excited to be here, and I really appreciate the warm weather and the sun. I'm from Michigan, so we don't see that much in the winter. And so for all of you that have stuck around, thank you. I noticed a mass exodus earlier, and I don't blame them because it's beautiful out. And apparently last year you all were snowed in. It's one way to keep everybody here. So today I'm going to talk about changing the system for vulnerable patients. I added in the slides our mission and vision from the National Center. I don't think we could have come up with a longer title had we tried. That was a Jeff Brenner compromise, the National Center for Complex Health and Social Needs. Our objectives for the day, so we're going to define superutilizer, or complex care patient as I call them. We'll talk about some lessons learned from the field and the ingredients for success. For both building interventions and inter-system collaboratory interventions. I've spent a lot of time over the past 18 months at the Camden Coalition working across the country with both FQHCs, with healthcare systems, and we're doing a project in Memphis right now with an entire community, and really have gotten a great feel for what works well, what hasn't worked so well, and what we need to do moving forward that will really make a difference in care. So we're going to define the superutilizer. I have boys who love this movie, and I thought it's a great picture. Also, he technically would be considered a complex care patient, with the, not anymore, but unfortunately. So, our complex care patients. I'm going to tell you a little story, because this is always my favorite. I love to tell patient stories, and I love to tell stories from the field. So you might, if I see y'all rolling your eyes, I'll know it's time to move on. So in my career, I worked for a payer, so I've worked in many different spaces throughout my career, including behavioral health, medical, hospital. I worked for a payer for about 6 years, which was a really eye-opening experience into how the payer system works, but that's a whole nother lecture. So in that role, I did some case management work with our most complicated high-frequency patients. I was the only one in the behavioral health department who had any addiction knowledge. So automatically, I came in and within a year got all these cases dumped on me. So I worked with this patient. Her name is, we call her BMAC, and that's her initials. That's not her favorite food. So BMAC was the $1 million patient. I mean, she's the patient that was in the hospital 4 or 5 times a year, plus in the ED 100 to 200 times a year, easily. She was complex medical, she was complex psych, addiction, and if you ever tried to manage a case like that doing telephonic case management, it's impossible. I learned a lot from that space, and I had the fortunate opportunity of actually working with BMAC in person. So the clinic that they briefly mentioned that I helped start with an ER doc, Dr. Corey Waller, we built the ambulatory ICU, which is really a fancy word for a really high-intensity, team-based primary care. And Barb, or BMAC as we call her, was one of our first patients. So I really got to see her and learn her story from her. And what I realized in working with her was all of the systems that she touched all had their own story they created about her. Whether it was psych or medical, she's non-compliant. So you start to hear all the buzzwords, non-compliant, acting out, borderline, which is always my favorite in my field, social work. She's a quote-unquote addict, which I'll tell you is very stigmatizing, so all of you out there, stop saying addict. And she had the label of, she was not using her meds, or she's coming to the ER misusing meds, the typical. But what I realized was nobody really knew her actual story, and the other piece is nobody was paying attention to what was in her chart. Now granted, her chart was huge. I mean, 5 inpatients a year for 6, 7, 8 years. That's a lot of chart. But all of the information about her was all on the chart. But we don't have that time in our world to really dig into charts like that, unfortunately. But we need to make it, because it makes all the difference in the world. So, she's my patient now at the clinic. I'm seeing her every week. I learn a lot about her. I learn about her story. I learn that she has a history of early life trauma. I learned that she has a really significant problem reading and writing. I learned that she has a pretty low IQ. I think it was about 88, which when you're doing therapy makes a huge difference if you don't know that. I learned that we, as in the healthcare field, see, criminal justice actually gets a break from this one. We're going to blame healthcare for the problems with this addiction, but we created the problem because we kept giving her massive amounts of narcs in the ED. And this was years and years and years ago, but it started the ball rolling. She ended up with a pretty significant opiate use disorder that was fueled by primary care, because she was the patient that called 40 times a day. And I'm not kidding you, the most she ever called our office, 50 times in one day. So any of you who work in healthcare, you all have at least one patient like that. Yeah? So she was the patient that they just wanted. They would write her prescriptions, and then they would fire her, and on to the next provider. Well, fast forward that 10, 15 years, and now we have a woman who has cirrhosis of the liver from acetaminophen. We have a woman who has diabetes, pulmonary hypertension, out of control addiction disorder, mental health issues, and had really no treatment. The only saving grace for her is she had a really stable family life. She had a husband who was, I hate to use this word, but was really, really normal. Worked, didn't have any addiction disorders, wasn't abusive, was a great guy. And I think that was the only thing that kept her from falling further into that space of homelessness, in and out of incarceration, etc. So, unfortunately, Barb passed away a year ago, but because of that relationship I was able to build with her, I actually did the eulogy at her funeral, and it was pretty powerful. And I think while by the time we got her into our space, we weren't able to really fix or make things better, because she was so sick and she was not a candidate for a liver transplant. But what we did do was we provided her a safe space and an authentic healing relationship, or as I heard it called today, that connection where she felt safe. And we gave her some of her life back with her family. So instead of all the conflict and the chaos, she had the last few years of her life, at least some peace and quiet at home. So, I haven't defined superutilizer yet, but I'm gonna get there. And Barb was a great example of like the ultimate high utilizer. But first we need to ask, what's the problem we're trying to solve? So when we're looking at doing interventions, whether we're working in the community, whether we're creating system interventions, multi-system interventions, or whether we're just looking at like a pilot in our own agencies, we have to start with first, what's the problem we're trying to solve? My 16-year-old can solve this in 30 seconds or less. It's amazing. So before we even begin to co-design or design any type of interventions or pilots, we have to do a little bit of pre-work. What's the goal of our intervention? It should be achievable. What does that mean? Well, it should be world peas versus world peace. I can make world peas. If anyone here can make world peace, I'm on board. The second is, who's our target population? So now we're gonna get into defining the superutilizer. So who exactly is a complex care patient? Well, I bet you we all have certain definitions, but patients who frequent the systems, whether it's the ED, inpatient, ED and inpatient, Imaging, lots of imaging, pharmacy, corrections. We have patients that are high utilizers of correction system. We have patients that are high utilizers of EMS. So what population are we working with? Because when we say we're going to target a complex care patient or high utilizer, we need to define that because there's many subpopulations. So for an example, Barb, or BMAC as we called her, she, high frequency inpatient and ED, much more medically complex, requires a much different team intervention than like the typical high frequency ED user. I mean, typically our high frequent ED users are people who have addiction disorders, chronic behavioral health, some chronic medical, but nothing really complex. Your poorly treated diabetes, high blood pressure, et cetera. But also tend to have a ton of social determinants or social correlates of health, as well as early life trauma. So that's one population. High inpatient, totally different. Oh, and then we go into the frail elderly, and yet another subpopulation. So really, having a really clear understanding of who is it we want to target. Do we want to target high system utilizers? Because that's even a different one. Someone that's hitting hospital and social agency and corrections all, because there's those patients as well. And then, how do we define this? How do we define, what did I do with the clicker? Oh, there it is, sorry. How do we define who we're looking at? Data, love data. I'm a social worker, but I'm a math geek. Love data, and you really have to know what the data says. So a great example of this, we have a hospital system we work with in California, and they were certain their highest cost patients were elderly. Well, their highest cost patients weren't the elderly, which we knew, but they didn't believe us until they saw the data. Most of them were the typical high frequency inpatient or ED, behavioral health, addiction, chronic medical, but not too complex, except in Central Valley. The highest cost patients in Central Valley were kids with asthma. Yeah, totally different. But if you don't look at the data, then you're not targeting the right patient population. So just saying, we're going to develop an intervention for high frequency ED and not know who we're developing it for can lead us down the wrong path and a lot of wasted money. So, does everyone like Dilbert? I love Dilbert. So again, which I just went over, but how do you know your target population is who they say they are? How will you measure success? So anybody who's been in any space of getting grants knows that if you don't have outcome measures, your likelihood of getting additional grant funding is really minimal. If you're working with payers, the same thing. When you're doing a pilot, you have to have outcome measures. So what data are you using that will measure success? Are you looking at inpatient stays, cost data, length of stay data? Are you looking, there's a ton of data points, pharmacy. These are all really important pieces to look at. I could share a great story about the Camden Coalition. I'm going to dog on the Camden Coalition for a little bit about some of our not so great interventions. So for those of you that aren't familiar, the Camden Coalition of Healthcare Providers has been around for 15 years. It was started by Dr. Jeff Brenner, who's a primary care physician who got very frustrated with seeing patients and not having enough time and not having enough reimbursement because he saw the Medicaid and uninsured patients in Camden. So for those of you that don't know, Camden, New Jersey is one of the poorest cities and most violent cities per capita for its size in the nation. It is growing up in Detroit and being in Flint for a while. It's just like Flint. Flint, I don't know if any of you have ever been in Flint, Michigan, but Flint, Michigan is like is dilapidated at this point. So anyway, back to Camden. So Jeff created, with his team, an intervention specifically targeting high-frequency inpatient users. So 3 or more inpatient stays in 6 months. A team went to the hospital, engaged the patients, and worked with the patients in the community. So the team would go to the patient home, and they would, get to know, build that relationship with the patient, but then when they link them back to primary care. So helping them better talk to their doctor, or getting them linked with transportation, or trying to get rid of all of those social determinants of health that can create huge barriers for people accessing care. And they did a great job. The intervention worked exceptionally well. So then they thought, well, why not add in high-frequency ED? So they decided to expand their population to high-frequency ED with this same intervention, without asking the experts in the coalition who work with high-frequency ED whether or not that would work. So it was an interesting space for a minute when we found out they were doing this. But what ended up happening is it failed. It failed miserably. It didn't take them but a few months to realize that. And I talked to the teams, the clinical teams on the ground, and they said, I don't understand it. So-and-so walks by their primary care office every day just to go to the ED. Or so-and-so is going to multiple EDs, walking by several different primary care offices. Why won't they go to the primary care? And the answer is because that's not the issue. And so when you start to really understand your data, you can find this out. So ideally, the best thing to do would be to be able to go out in the field and talk to the patients and realize why they're going to into the ED all the time, or why they're in the hospital, or why they have all these pharmacies, or et cetera. We don't always have that luxury. But if you know how to read the data, or if you have access to the data, it tells you all of that. If I see my top 25 ED utilizers with admitting and discharge diagnoses of pain, malingering, what's the other one, drug seeking, those kinds of things, that tells me one thing. But if I see my top 25 utilizers with asthma, or what I see all the time across the country is end-stage renal disease, that's something different. Why are all these people coming to the ER for dialysis? Well, they've either been fired for behavioral health issues, which I don't even believe. The fact that we can fire people from dialysis is just unethical, or from any care, really. But the other is they're undocumented. So those are very different interventions. Learning how to look at that data tells you who you're engaging with and why, and it helps to build a better organized coalition of care. And then how about sharing data? Are there any HIEs around here? Yes, no, no. Is it Health Information Exchange? Do we have HIE? Is behavioral health also part of it? That's not very common. How about corrections? Jail, no? Yeah. I've only seen one community so far have everybody involved, but that's a start. Are we sharing data with one another? Are we talking to one another? So, several data points. Imaging isn't one that people tend to look at, but especially if you're working with the high utilizers of the ED, they get a lot of imaging. And so sometimes looking at that data can be really helpful. There are multiple ways to look for data, and this is just a brief. This in and of itself is a whole lecture, a whole hour lecture. So we have a lot more resources on our coalition website, which the website will be in the PowerPoint. So the last point in this piece of pre-work. Does anyone else like Futurama? Awesome. Oh, wait, go back. Okay, so knowing who's in charge. So this is a really important piece, because how many people have been in meetings before where you've taken time out of your day and you're sitting in a room and you're talking about things that are really important and you want to change, but you're not really sure who's in charge? And then you walk out of there thinking, I'm not sure what we're supposed to do. Yeah. So that's a really important piece. So if we're talking about system or multi-system collaboration or community collaboration, who's leading? Who's leading this collaboration? Because one person or one space has to at least take that initiative. That doesn't mean you don't share power, because of course you share power among everybody, but having that who's in charge leadership set up at the front end will offset much disaster on the back end. So things if only I knew before I started. So I love to snowboard. I took this up in my early 40s, and I have never ended up in a tree like that, yet. I almost did last year in Colorado, but fortunately I'm still here. So the big thing about this, I am going to share some lessons learned from our own experience, because there was one really big lesson that Corey's the physician that I started the clinic with. There's one big lesson that Corey and I learned a little bit too late, and that is engaging and having support from your C-suite. So whoever your executive leadership is, whether it's a hospital system C-suite, whether it's whoever your primary care, it doesn't matter what agency, you have an executive leadership team. Unless you here are the executive leadership team, then it sounds like you'd probably be supportive if you're sitting in here listening to me ramble. C-suite is huge, because if you don't have support from your executive leadership, it doesn't work. And I can tell you this firsthand. We developed this clinic without support from leadership. And while the clinic is still going, and we have had incredible success, we have a complete team-based approach take over all care. We've reduced costs to our payers 43% year after year after year. I mean, we have done an exceptional job reducing utilization of the system and stabilizing, improving function of the patient. But the C-suite never was supportive. And so now it's this battle every year to try to get them to support, because it's an expensive intervention. Any type you're intervening with complex patients, it's expensive, because these are expensive patients. And we have created systems such that we make it expensive like that. So in any case, C-suite support, senior leadership champion, and also having someone from your data and finance team to help. Whoever that is, whatever agency, having that data support is really helpful, because not everybody either has access to the data or knows what to do with it. It took me years to learn how to actually run good reports and read them, and I still have a lot to learn. But fortunately, I have people on my team who are really good at that, and they love it. So I'll share another brief story about why you have to have C-suite support, and also knowing how to approach your C-suite for support. Because know your audience, right? Who you're talking to. Well, how you approach the C-suite is going to be different than how you approach the payers, how you approach the social workers or physicians, or how you approach another agency. I have a good friend and a colleague who started this amazing complex care program in a hospital system, and had a pilot. Make a long story short, after a year, and they analyzed the first 100 patients, saved the hospital system over $1 million in cost, and also reduced utilization significantly for these patients. So she goes into the C-suite, presents all this data, and at the end of her talk, the CEO of the hospital system, and this is a huge system. This is Trinity Health, which I don't know if there's how many Trinity facilities are around the West Coast, but there's like 92 hospitals. This is a huge system. So the CEO for Trinity says to my colleague, I just want you to know that we're going to hold you personally responsible for any loss of bonuses this year. Why? Because she reduced utilization. And when you're a hospital system, that's what keeps your bottom line going. So while she's thinking, I just created this intervention, we got rid of all of this unnecessary care, we've reduced utilization and access, frequent access, and then she hears that. But fortunately, he was very supportive of this intervention and building this complex care program. So he actually did a lot of mentoring with her and taught and worked with her on how to approach these populations, C-suite population and executive leadership, and how to have those conversations in a different way. And some of that starts with sharing a patient story, like it did about Barb. So that's an important lesson, and it's an important piece to know, is that we have to have that C-suite support, but we also have to know how to talk to our C-suite. We love silos. We do. And you know what? The thing I love most about silos is how effective they are. I'm a little sarcastic at times, but for people who have been around in the field for a while, how many times have you heard we need to break down silos? But yet, we're still not doing it, right? I tell you what, we're not going to solve these complex problems without it. So I was having a conversation at lunch about the opioid epidemic, which is just as much of an issue here as it is actually in Michigan and Kentucky and the East Coast, in New Jersey and Philly. It's everywhere. California, it's everywhere. Having worked in addiction for 20-some years, I can tell you what we do in addiction treatment doesn't work either. We have really good evidence-based treatment for opioid use disorder. What we don't have is the ecosystem to support it. So it's not just about adding a bunch of docs who have MAT or have buprenorphine waivers. Now that's a start, because if we don't have access, we can't move forward. But it's not just about that. It's about building a whole new ecosystem. And I can tell you, in all of the work I'm doing around the country, the only thing that is going to make a difference in this epidemic is creating an ecosystem where everybody plays together in the sandbox. It's the only way, because our patients touch multiple systems. Addiction, anybody who's worked in addiction or has worked in that space knows addiction patients touch multiple systems. And when you have people who have chronic disease especially with opiates, and methamphetamine, which is also an issue out here. I mean, people deteriorate pretty fast. Not as much with pills as heroin, but in any case, our patients are touching EMS, right? EMS is going out and Narcaning, and then they're taking them to the ED. And the ED is doing what? It depends on your ED. Some of them nothing. Some of them are actually starting Suboxone. And then when they're in the ED, what we love to do is we hand them pieces of paper with phone numbers, right? So anybody out there tell me, is that effective? I mean, it hasn't worked in my experience. Maybe other people's experience it has, but handing somebody who just got their high busted and is now dope sick does not care about a piece of paper that says, call behavioral health at, or show up to such and such clinic tomorrow at 4. Whatever, their whole goal is to not be dope sick. So, if we don't start working together and creating ecosystems that include police and fire and EMS and jails, probation, parole, drug courts, hospital systems, DHS, or whatever you call Department of Health Services here, the CP, Child Protective Services and foster care, the legal system, as in like legal aid, outpatient primary care, behavioral health. In Washington, behavioral health or mental health and addiction is one, correct? They're not two separate services, or are they two separate? They're separate. It depends. It's the same answer I get everywhere, yeah. So that would be, it's a huge undertaking, but it's the only way this problem's gonna solve, because it's such a massive problem, and all we do is push it to another space. So we put them in jail, they go through withdrawal, they come out, and sometimes they overdose because they're now opiate naive. Or we get angry because we're Narcaning them, the same people, 3-4 times a week. And then we're frustrated, and now I see legislation around the country about like 3 strikes and you're out, and people, I can see across the audience, for some people that seems reasonable. So I think if we're gonna do that though, we need to also do that for all other chronic disease. So if you show up at the ER and having a heart attack, if it's your 3rd heart attack, we're not treating you. Or if you are having a stroke because your blood pressure's so high and you're not taking your blood pressure meds, 3rd strike and you're out. Or diabetes, right? Oh, we've already amputated 2 parts. We're not gonna do it again because you won't control your sugar. What would happen if we did that? The ACLU would be all over that. And the reality is, you're all thinking that would be horrible, I would hope anyway. That's not good patient care. But there's so much stigma around addiction and mental health that we don't want to treat it like a chronic disease, even though it is. And so these are important pieces of the puzzle. But ultimately, breaking down silos are the only ways we're going to solve tough problems. So part of how do we start doing that? Well, we identify who's our cross-continuum team, meaning who all are the people in the community that are working with this patient. Because identifying that first makes such a huge difference. How many times do we sit in meetings and have all of these preconceived notions about what this agency does or what that agency does or who this person is, or we don't like that person, but yet we never really even talk to one another? Or how often do we get frustrated as social work when we call a primary care office, except not Marcia's, but when we call, and if there's other docs in here that I don't know, maybe not you either, but we call, social workers call, and nobody wants to talk to us, right? I can't get anybody to call me back. And then so I have to have the physician I work with call to even get an answer. Those kinds of things are frustrating. So identifying who's all touching the patient. And it allows us to then start reaching into our own system. Who in our system is also working with this patient? Who in our community is working with the patient? Because ultimately we have to stop reinventing the wheel, right? Because how often do we see programs in each community that do one thing slightly differently? So my favorite example is the community that has one agency for socks, one agency for coats, another one for food, and another one for other, like just jeans and other regular clothes, and then another one for housing help, and what did I do, like 5? That's just to get some basic needs met. Now, for our patients who have really complex needs and a lot of social determinants, telling somebody to go to 5 different agencies just to get an outfit and a coat and maybe a chair to sit in is pretty unrealistic. So, what are some tools? Well, one thing we need up front is a business associate agreement. Do you use those at all here? Yeah, excellent. And that allows us to talk to one another. And we use those are really important when we're working with agencies outside of our own healthcare system and outside of the healthcare system in general. And there's on our, there's a link on there that we have a sample business agreement. We have business agreements with all of our technical assistance sites so that we can share freely information. And then having one contact person, right? So we're designing a community intervention that's going to do something better about the opioid use disorder. Someone has to take the lead in this intervention or in this collaborative. Who's that contact person? Because there has to be a person who is able to answer questions, or else you get the typical, you call here and you get one answer, and you call there and you get another answer, and you call there and you still get a third answer. So the more centralized communication we have in one space, the better it is. Huddles. So team huddles and cross-community collaboration huddles. Everybody, we're in Seattle, right? Y'all have great technology. Use Zoom. We Zoom huddle every week at my team. And we're all over the place. The more you can be in the same space, the more you can start to really work together and understand what are the needs of the patient, what's going well, what's not going well. And you can have these huddles, you can do these in 15 minutes. It's just a matter of touching base and having a format. What are we gonna do first? What's working well? What are our barriers? Where do we go now? Which also, huddles really help to coordinate care. But these are some of the things that we start to look at when we talk about tools for breaking down silos and building partnerships. Looking at who already exists and looking at who we can bring into our collaboration. And having an integrated consent. I see around the country mixed issues about this. Some people refuse to do it. Others, in Michigan, we have an integrated consent where we have multiple people on one. Inter-organizational collaboration, case conferencing. It's possible. We do it. Bringing together every person who's touching the patient, who's involved in patient care, to the table. That includes corrections. That includes APS or CPS. That includes everybody who's involved in this patient's care. And you can do it. You can do it. You don't need a ton of time, but if you can have everybody in the same room around the same table talking about the patient, what it does is two things. It starts to break down barriers, and it also allows everybody at the table to share that common patient story. And it's that common patient story that is a really important link for all of us, because everybody is here today for one reason, because you want to make change. You want to do something in your community, in your agency, that's actually going to provide better care. Whatever it is you're due, you're here because you want to provide better care for patients. And that is a really important piece. So bringing everybody to the table is a start. And it doesn't mean that you do this every month. It may mean you only do it once when you first take on a patient. But the other important piece of having a conference like this, a case conference like this, you have to have somebody in charge who's good at moderating, so that everybody at the table has equal space to talk, and everybody at the table has equal space to share their concerns in a safe environment. And if you don't, it can be disastrous. I mean, we've all been in meetings where there's a few people that dominate, and the other people who are more introverted will keep to themselves. So having a good moderator in that space, and even if it's someone who's not on the team, having someone to moderate that space is really critical. So again, solving complex problems with shared resources. Resources are scarce. That's why we get very protectionist of our silos, because we're all fighting over the same resources, except the reality is we're all reinventing the wheel and duplicating services because we don't want to play with each other in the sandbox. And that's a really important start for building a new ecosystem, is just learning how to sit in the room together and talk and have some structure around what are we going to do as a team, because everybody who's involved in patient care is on the team. So this is a framework we use at the coalition, but the more we work together, I mean, ultimately our goal is to provide better care at lower cost, or to do what's right for the patient. I mean, I live by that. Always do what's right for the patient first, even if it's not what the system likes to hear. But sometimes it's really hard. But what we know is if we do what's right for the patient, we're gonna end up providing better care at lower cost. So I wanna bring this all together and show a video. So I've done a lot of sharing about lessons I've learned. Now, I can tell you there's been some great successes around the country. I'm just wrapping up a 3-year project in California working with FQHCs. And I am starting to think that FQHCs, or federally qualified health clinics, may be one of the better spaces to add medication-assisted treatment programs, because they're already have behavioral health embedded, and they're already treating that population. Because if you have FQHCs, especially in rural areas where you have a primary Medicaid population, which in California this is becoming a huge issue, then they're already getting those services there, and they already have the resources there. But in any case, we've had some great successes in California. We've had some great successes around the country, on the East Coast, in Memphis. And one in particular, one more second. So one in particular is when we talk about community collaboration. I want to show you a video of a site, or I shouldn't say a site, a community in Northern California, Clear Lake. And I want to show you how they have actually figured out how to break down these silos and work together as a community. And they put together this beautiful video. So thank you.
A year ago, I was homeless. I went through divorce, depression, alcoholism. It started so fast that there was no going back, it seemed. When you're homeless and when you're using and drinking, you neglect everything. One of those nights that I was drunk, I got hit by a car. I was walking with a broken hip. I was close to dying, and I really didn't care.
A lot of times by the time we show up, it's gone way beyond what it should have, because they really don't want help.
Just this last year, we did 27,000 incidents, and you sometimes don't think about what led up to that situation.
And the story starts with a lot of desperation, sadness, hopelessness.
From homeless to getting sober, then now what? You know, I didn't have a plan B.
We need to fix the broken system.
What can we do that is going to have a county-wide impact?
If we can break that cycle and give them a little bit of help to get them back on track.
If we can coordinate all the services that are available and have them work together, it will be far more powerful.
The question ceased being what if to when and how.
Restoration House is a place for people who are experiencing significant medical issues and are also homeless or at risk of becoming homeless. We provide intensive case management, a safe place to heal, and also a place where they're accountable for their choices and their actions.
this was something different. To change the whole concept of healthcare and caring for individuals, if we don't have a house, and we don't feel safe, and we don't have food, then we're not going to be healthy.
When they commit to the program, I sit down with them and I talk about, where do you need help? And we walk them through the process of what they need to do to get well.
From here, the goal is permanent housing, but we walk along that path with each resident so that they are ready when it becomes available to them. Change is possible.
A program that reaches out to them and makes that first move can make an impact.
To see that individual later on being a productive member of our community, having a job, treating their kids properly, treating their family properly, that to me is tremendous.
This is a new beginning.
I just finally had someone that had faith in me. Restoration House has given me everything. Having my kids say they love me, finally.
You can't change the past, but you can change the future. And together we are doing that.
So, I guess now does anyone have questions? Yeah.
What's your opinion regarding safe injection sites?
It's interesting you should ask that because I said that earlier. I think that safe injection sites are actually a really appropriate use of a space because you're going to have people who just don't want to quit using, and so providing them a safe space is not a bad idea. It's no different than our diabetics who don't want to stop eating Krispy Kremes, or our heart disease people who still eat McDonald's. I mean, we can go down the list, but yeah. They're very controversial in the United States, that's for sure. I know they have one in Baltimore. Did they open one here in Seattle? Yeah. Not yet. Okay. Yeah. Okay. Yeah, I saw some in the paper on that. Anyone else? I mean, when we talk about high utilization patients or complex care patients, we have to always start with a harm reduction approach. If we don't, it doesn't work. But if we can help people stabilize and use less, that's better than what they were doing before. Anyone else? You are like, I want to get out of here. It's sunny and nice. And I hear it rains a lot here in Seattle. Anyone? No? Well, thank you so much for inviting me out to speak. It's been a great day for me. So.